So I'm realizing as a parent, you know, you go through two phases. You go through a phase when they're really young, where you don't get any sleep because they're crying at night, they're teething, they're sick. And then you go through the teenage phase when they're out late at night or they don't come home and you're worried and you're up all night. So my son last night, I'm getting ready to go to bed and he's making a big cup of coffee and I'm like, where are you going? And he says, I'm going to study. I'm going to UD, the library. They're open until 5 a.m. And I'm like, what? I didn't even know that. So he goes, have your ID card in case they ask me for an ID or something like that. And so I'm like, I guess. But it's like, I cannot sleep when my kids are out of my house. And I'm thinking he's going to get mugged over here coming out of the parking, coming out of the library over in B lot about, 3 in the morning. So he's taking, my son, he graduated early. Well, not graduated, but he finished his classes in December, but he still has this one online Spanish class he has to take. And he was supposed to do it last summer. He goes, he had signed up for this thing for a year. Well, time runs out in March at the end of this coming month here. So he's got 1 month to finish this class. It's a full year Spanish class. He is 10% done. He has 90% to do. And he's working full time at IKEA. And now he's whining and moaning how he's all stressed. And I'm like, dude, I don't want to hear it. But so he's just making, bad decisions. He'll learn from it. It's good. It's good for him to sweat a little bit and then know he never wants to be in this position again. Although I guess he can extend the class a little bit, but it's going to cost him like $400. So that's like, we're not paying for extensions. This is on you. So yeah. So I heard the garage door open about 3:15 this morning when he finally got back from studying. Then he'll waste the whole day today, ruin the whole day for studying because he'll be sleeping. But anyway, what can you say? I'm sure none of you make those kind of decisions, right? So, all right, we're going to go through some cranial nerves, all 12 of them. Some are more important than others for us as PTs. So we'll stress the ones that are more important. So you got 12 pairs, one on each side, right? And typically you have some paired nuclei that are associated with each of these. They're kind of like spinal nerves in a way, but they're in the brainstem, and one of them comes directly out of the cerebrum. They carry motor, sensory, and autonomic fibers, okay, kind of like your spinal nerves. However, in our spinal cord, we have kind of our dorsal horn, our anterior horn, and the intermediolateral, cell column or lateral horn that's associated with the sympathetic nervous system. They're all in this nice long column, right? And they're all right next to each other. Well, in the cranial nerves, they kind of are broken up and distributed throughout the brainstem. And you have separate nuclei for the motor part, the sensory part, the autonomic part. So it's a little more intimidating in that way. So you have just some different nuclei associated with different functions. And you do have then some specialized functions, special sensory functions: vision, hearing, taste, and equilibrium or head movement that's associated with the semicircular canals and the otoliths. Starting big picture, think big picture here on cranial nerves. They have three major functions: motor supply to the muscles of the face, eyes, tongue, jaw, and two neck muscles, okay? Then you have somatosensory function, information from the skin, the muscles, the face, the TMJ. And then these are not, I would say, somatosensory is different than the special sensory. And then end special sensory, so almost we could say 4 functions. We could have somatosensory, then special sensory. That's related to vision, auditory, vestibular, taste, smell also. I forgot to mention that earlier in the last slide. And then visceral sensation, okay? So you're sensing the viscera. That's vagus nerve that does most of that. Then we have the parasympathetic regulation. So this is the cranial part. You have the cranial sacral division of the parasympathetic. This is the cranial part. The cranial part does most of the regulation of the parasympathetic system. The sacral part does mainly the parasympathetic regulation of the bowel and bladder, okay? But that's for heart rate, blood pressure, breathing, digestion. So here's a real quick picture of all of those nerves. The first two are similar color to the cerebrum there, is the olfactory and optic nerve. Then all the rest they have shaded in yellow. Okay, so you can just see how they kind of come out of the brainstem. So you have number 1 here. This is number 2. You kind of start here at the top and work our way down. Then this is number 3 right here. Then you kind of start moving out. So you get to this junction between the pons and the midbrain. This is the junction between the pons and the midbrain. Then you have number 4 here on each side. Then you move to number 5. And then you move back into the middle again. So then you come back into the middle here. And then you have this. Now this is called the pontomedullary junction. You see there's a bunch of them coming out of the pontomedullary junction. Then you just start counting out along the side here. So this is number 6 here. Then you go to 7, 8, 9, 10, 11. And then you jump one fissure or sulci forward to number 12 right here. So kind of start in the middle, go down to the first junction, count out, come back to the middle, count out around. So you will not see a picture of, well, you might. I take that back. For the lab practical, there might be me highlighting one of these particular structures or nerves for you to pick out and identify. So, table, just got to know it. Got to know numbers and names. Okay. In the lab practical, you can write CN, abbreviate CN number 3, CN number 4, something like that. But for the exam, for the written exam, you want to know either the number or the actual name of the cranial nerve. You want to know its basic function. And you will want to know at least its general area that it connects with the brain or brain stem. There's all kinds of helpful mnemonics that you can look at that help you know or remember these cranial nerves. This is just one of them out there. I picked the clean one. There are some dirty ones out there, and unfortunately, that's what I learned in PT school. And once it's there, it can't go away. And so I won't divulge it, but you'll find it out there. Probably sure one of those versions of the dirty ones. Sometimes the dirty ones work better, but just that taps into that different part of your brain. So on the one side here, this is the mnemonic for the actual nerve that's itself, okay, so to help you, at least the first letter of each of those to help you remember those. And then on this side, so our cranial nerves can be either just sensory, just motor, or some combination of motor and sensory, okay. And so that's the other mnemonic on this side, gives you whether it's sensory, motor, or both, okay. I added this. I will re-upload this to the drive, to the Isidore. So this is something I just added last night while I was staying up worrying about my son at midnight. So starting at cranial nerve number 1, probably the one we least care about from a standpoint of PT, clinical relevance. However, you never know. You might have a patient who comes in with a frontal lobe head injury, and you might find that they have some difficulty with smell that might require further referral or something like that, or maybe the reason why they don't like to eat very much, because if you don't smell, food doesn't taste, you don't get much taste from food, okay? It's a sensory, pure sensory receptor. It's a chemoreceptor, okay? So it depends on the chemicals from the smell that fall on those olfactory receptors that then cause the depolarization and action potentials. Conducts information from those nasal receptors directly into the medial temporal lobe, and the medial temporal lobe is part of our limbic system, okay? So it has some very primitive origins. It goes directly into that limbic, emotional centers of our brain, so it definitely is kind of a primitive emotional responses we can have associated with smell, whether that's something really repugnant or something like grandma's apple pie that makes us feel good and those kind of things. So smell can have those kinds of effects on us. We have over 10,000 different scents that we can recognize that we usually recognize as a taste, okay? And often, and actually the flavor of most of our food is driven by the smell of it. So we only have some sweet, sour, bitter, salty, kind of basic tastes with our taste buds. The rest of our taste is influenced by smell. That's why when you have a cold, you can't taste anything. And that's why a lot of older adults, as they age, not only do their taste buds get less sensitive, and that's why you see them dump that half a can of salt on their stuff, and you're like, oh my God, how could somebody do that? Or their olfactory system and those sensors also go bad after time, especially if they're smokers or those kind of things. And then, so it's not pleasurable to eat once you get, you got to have to just do it to maintain sustenance. And that's why it's hard sometimes for older adults to feel motivated to eat, because they don't really get any pleasure out of it. All right. Maybe I should plug my nose up so I never feel like eating all the time. So that'd be my new weight loss program. You just come, they walk in, you just put a little clip on their nose, pull a clothespin, say, all right, you should be good for, leave that on for 6 weeks. Testing of cranial nerve 1. So if you're going to test this in the clinic, it's unless you have like some, orange or coffee or something like that, basically you just present the stimulus, something that smells. You don't want to use ammonia. Ammonia is a noxious stimulus. It's not really truly a scent. It actually irritates those olfactory receptors. You want to use some kind of a scent, whether it's a fresh orange, some lemon, vanilla, coffee. Those are all good scents to use. You plug one nose, nostril, you place it up, and then just ask them to tell you what the scent is. And you do it individually, so because you're stimulating each of the individual olfactory bulbs. Problem is, a lot of times somebody can have a problem with this just because of blockages of their nasal cavity. Okay, they might have a deviated septum, their nose is plugged up. Smoking can interfere with the test if they just had a cigarette or something like that. So those are things that can throw you for a loop on that. Difficulty recognizing all scents except ammonia, because ammonia is irritating, is called anosmia. If you hear the term anosmia, unilateral anosmia would just be one side of the nostril. Bilateral anosmia would be both. So yeah, Dennis. Irritating, and then it goes directly into the limbic system, and limbic system has some pretty direct connections with the reticular activating system in the brainstem, and so that's what generally secretes serotonin and norepinephrine up into your brain, and it causes you to try to alert or wake up. So yeah, but it's a very powerful irritant to the olfactories, and it's just like, whoa, I gotta get away from this because it's very irritating. You're saying there's a chemical that I won't be able to breathe if I have to breathe this chemical for very much longer. So. Optic nerve. This is important for us just because it's a safety thing. It's when you're walking a patient, if they can't see a certain region of their visual field, they're going to run into objects. Or if they don't have good vision, you're going to have to compensate with having them use a walker so they can feel the floor better through their hands because it's compensating for their vision. So those are things that you screen. Oftentimes, though, that makes me want to refer patients to either an optometrist or a visual therapist or something like that. Very common in stroke to have visual disturbances. MS too. Probably the most common first symptom for MS is a visual symptom, some kind of a field cut or a blind spot or something like that they get because of a lesion. Actually, in MS, optic nerve is very commonly affected because even though the optic nerve is coming off, it actually still has oligodendrocytes on it. Believe it or not, it's not Schwann cells. On the optic nerve, it's still oligodendrocytes. It's sensory only, okay? It has relays to both from the retina, from the back of the retina where the rods and cones are and the sensors. It goes to both the lateral geniculate nucleus, which is on the bottom and outside of the thalamus, and also to some pretectal areas in the midbrain. So remember we talk about the tectum of the midbrain where that superior and inferior colliculi is. So there's a pretectal area, an area just in front of the superior colliculus where some information goes, visual information also goes into the brainstem. From the lateral geniculate nucleus, it goes directly to the visual cortex via the optic radiations, the primary visual cortex in the occipital lobe. Information going into the midbrain, okay, that in the pretectal area, it helps to drive basic pupillary reflexes, awareness of just light. You can actually see whether if you have cortical blindness, people that have actually damage to the occipital lobe, they can still tell light and dark because your brainstem will actually sense just whether there's lightness and darkness in the actual midbrain region. So basic awareness of light. And also, remember we talked about when you see something in your periphery or something in your visual field, you tend to direct your eyes to it. That's mediated at the brainstem level via the superior colliculus and its connections with your tectospinal tract, which is through the medial longitudinal fasciculus that goes down to your neck muscles to tell it to turn. So this is a very simplified diagram of those pathways, which is all you need right now. There is some information crosses here, but we don't really worry about that right now. We're not worried about the crossing and the chiasm. Just know that here's the back of the retina. Information comes in. A lot of it goes this way. Some of it crosses, but one place it goes is the lateral geniculate nucleus. And the thalamus sits right here on each side. And this is a bump on the bottom of the thalamus, but more lateral. Okay, there's also a medial geniculate nucleus for hearing that sits back here, but it's a lateral geniculate nucleus. So it's sitting off the back of the thalamus. So that information comes in, makes a connection. It goes around this little loop here called Meyer's loop because it's actually going around one of your ventricles. The inferior horn of your lateral ventricle has to get around that. So that's why it kind of loops around, then goes back to that medial part of your occipital lobe right on the lips of the calcarine sulcus. Remember that calcarine sulcus that divides the lingual gyrus from the cuneus? That's where that information goes, okay? We also get some collaterals that come off the optic nerve here that go to this pretectal region right here. Here's our tectum. This is our superior colliculi, bumps back there. So there's some branches and collaterals that carry some of that optic information to the pretectal area. So testing. So optic nerve does quite a bit, and some of it requires some specialized testing. We can do some basic screening. You know, if you have a patient who you're just wondering about their visual and you're going to be maybe referring them on, you can do a few things. So one thing you can do is just look at basic pupillary light reactions. The optic nerve is the afferent part of this. You have to get light into the brainstem for it to then send the efferent part, which is through the oculomotor nerve, back out to the pupil to constrict, okay? So it's kind of like a reflex in your knee. You got the afferent part where it has to travel up the sensory nerve when you stretch the muscle spindle. That's what the optic nerve is bringing the light in, okay? So if somebody has poor pupillary reflexes, first of all, if they see the light, then the optic nerve is probably okay. But if they don't constrict, then it might be oculomotor nerve that's the problem. But typically with oculomotor nerve problems, you're also going to have trouble with their eye movements because the oculomotor nerve also innervates a lot of the muscles that move the eyes. So generally if you shine a light in their eye, the pupils constrict, they can see the light, and you also get the consensual, which is if you shine light in one eye, the other eye should also constrict because they're all connected together. Then you've got both the afferent limb and the efferent limb of that light reflex intact, especially then if they also can move their eyes in all directions. However, if you put light in their eye and it doesn't constrict, and they also have difficulty with eye movements, then it's probably more of a cranial nerve number 3 or oculomotor nerve problem. Okay? There's also the accommodation reflex. This is also the afferent part of it. That's where you have to focus your eyes on near objects. That's accommodation, which involves bringing the eyes slightly together, having the curvature of the lens increase the curvature of the lens to focus that object better on the back of your retina, and also you get a little bit of pupillary constriction. So the accommodation reflex involves adduction of the eyes, some change in the curvature of the lens, and also a little bit of pupillary constriction. This is how you accommodate to near objects. We can do visual fields, so we screen visual fields, okay? When can they see objects coming in from different directions, from the peripheral fields of vision, and then also acuity, which is just the little miniature Snellen chart there that I've got in front of you, okay? So let's, real quick here, I'm going to do a quick screen of somebody here. Now, there's not a great place up here because you guys are going to have trouble seeing what's going on here. I'm going to see if I can do maybe, can you guys see kind of over here if somebody sits right here? So, do you want to come up real quick? Are you okay?
Yeah.
I'm going to pause this because I don't necessarily need to record all this. We will do this again in neuro in the fall, review some of this stuff. Okay, now we get to crank out 3 cranial nerves at a time here for the next one here. So we're talking about cranial nerves 3, 4, and 6, okay? Combined, they are what do primarily control of movement of your eyes, okay? They do assist, or at least cranial nerve number 3 does, with the reflexive constriction of the pupil. That's the efferent part, it's the motor part. You know, but we just talked about the afferent part of that pupillary reflex. This is what actually causes the pupil to constrict. And that is via the Edinger-Westphal nucleus. So it's actually a small parasympathetic nerve nucleus that drives that constriction of the pupil is parasympathetic fibers that do that, okay? And that's a little extra nucleus in there. It's a separate part of the oculomotor nucleus. It's called the Edinger-Westphal nucleus that has those few sympathetic fibers that cause the pupillary constriction. Mostly what your oculomotor nerve does is it drives the extraocular muscles, the muscles that move the eye. Okay? It also does, though, assist with elevation of the eyelid as well. So cranial nerve number 3 assists with elevation of the eyelid. Here's where we have three separate, we have the nuclei that are associated with eye movement are, first of all, cranial nerve number 3. There's the oculomotor nerve, which is controlling a lot of the eye movement, the extraocular muscles, but also there's the little subcomponent called the Edinger-Westphal nucleus that has those parasympathetic fibers that help constrict the pupil. Then we have the trochlear nucleus, which is got the cell bodies for the trochlear nerve. That's going to go supply the superior oblique muscle. And then we have the cranial nerve number 6, which is called, the nucleus is called the abducens nucleus. Abducens, it abducts the eye, and it's the cranial nerve number 4. I'm sorry, 6. Cranial number 6. Sorry about that. So control of eye movement, it can be a little confusing at times. There are six extraocular muscles. You have 4 recti muscles. Rectus means straight, and they kind of do what you think they should do. They move the eye in, out, up, and down, okay? So that's a superior, medial, lateral, and inferior rectus. So you can see these are the primary motions that each of these does. Then we have, so superior rectus, moves the eye up, inferior, straight down, lateral rectus, mostly straight out, and medial rectus, mostly straight in, okay? Then we have our oblique muscles. We have a superior and inferior oblique muscle, okay? And they have more of an oblique attachment, where they're an angled attachment to the eye. They will, if your eye is in an inward position, your eye is in, when it's in order to go in and up, you use the inferior oblique to go in and up. If you use the superior oblique to go in and down, okay? So it's a little bit counterintuitive that the superior oblique makes your eye go down and in, and the inferior oblique makes it go in and up. All the muscles are innervated by cranial nerve number 3, with 2 exceptions. And if you just know the exceptions, then you don't have to memorize the rest. So superior oblique is SO4. If you kind of remember it like a chemical equation, it sometimes helps a little bit. So SL4, LR6. Lateral rectus is 6. Superior oblique is cranial nerve number 4. All the rest are cranial nerve number 3. This is looking down from the top. The only muscle we don't see in here, we don't see the inferior oblique. It's kind of hidden here. You can see the superior oblique has this kind of weird way that it attaches. So it comes around, and there's this little ligamentous structure here that on the inside of the eye socket here that it hooks around to give it this oblique entrance here to the top of the eye right there. This is a really good short video that I'll show you. Unfortunately, I don't think the sound is working, but hopefully you can, I'll turn my sound up as high as it'll go. See if you can sort of. Oh, really? Okay. But this, at least visually, you'll see what's happening with the eye movement. It's just good to see what's actually happening. And some of the eye movement depends on whether your eye's turned in, and that's when the inferior and superior obliques will help move it up or down, versus it turned out a little bit. And then there's also when the eyes are looking straight ahead and not turned in, the superior oblique will rotate your eye or extort your eye, and the inferior oblique will intort your eye. It'll like turn it like that. And you'll see this in the video. I think it shows that. Hang on here. I'm not getting any sound right now. Of course I'm not. Let's change this back to my speakers.
So I want to watch a video on eye movement. Hi, understanding the